Morning, everyone. Please be seated. Before we start, let me remind everybody that the completion of the surveys are important to maintain our CME accreditation and continue to deliver appropriate content for you. Regarding video conferencing and videotaping, we are videotaping and live streaming. Please use the microphones in the area to ask questions, and a video of this conference will be available on the DeBakey Education YouTube channel next week. And with that, it is my great privilege to introduce the speaker for Grand Rounds today, Professor GIAN PAOLO USSIA. He is an interventional cardiologist and associate professor at the University of Rome, Tor Vergata, Italy. He is also the coordinator of the systematic pathology course at the International School of Medicine at the University of Rome. He graduated magna cum laude in medicine and cardiology from the medical school in Bologna in 1996 and was a pediatric and adult interventional cardiologist in Modena, then in Genoa at the Giannina Gaslini Children's Hospital. From 2002 to 2012, he worked at the University of Catania at the Ferrarotto Hospital as the director of the Structural and Congenital Interventional Cardiology program. He has been at the University of Rome since 2012 and is currently associate professor and coordinator of the Valvular and Structural Interventional program at the University of Rome Tor Vergata. He is credited with a number of first-in-man procedures. Notable amongst them was the first transcatheter aortic valve implantation in Italy with the core valve bioprosthesis, the first MitraClip implant in Italy, and the second one in Europe on the 7th of October 2008. He's also credited with the only two successful transeptal transcatheter mitral valve replacements with a dedicated device. He is an international proctor for Edwards, St. Jude's, Medtronic, and Symetis, and has performed more than 900 transcatheter aortic valve implantations, 250 MitraClips, 3,000 PCIs, and more than 2,000 structural interventions. He is the coordinator of the Italian Working Group for Interventional Cardiology, the associate editor for Journal of Cardiovascular Medicine and European Heart Failure Journal, has co-authored more than 120 peer-reviewed manuscripts, 400 abstracts, and 10 book chapters. Today, he's going to talk to us about transcatheter mitral interventions, the past and the future perspectives. Dr. Ussia.
Good morning to everybody. It's a really pleasure and honor to be here to give the Grand Rounds. And thank you for the invitation. So I will talk about state-of-the-art and future perspective of transcatheter mitral valve intervention. The first talented Italian who described the mitral valve and also its function was this man, Leonardo da Vinci, and he already understood how complicated was the mitral valve. And in this page, he was able to describe the valve and also to understand some function. We know that mitral valve is very complicated valve because the good function requires the perfect coordination of leaflets, chordae tendini, papillary muscle, annulus, left ventricle. Until now, until 2007, 2008, the only transcatheter treatment of mitral valve disease was balloon valvuloplasty. And it was very effective, and this is a first indication in the selected patient. Mitral valve disease is very common, mostly are mitral regurgitation, and we have two kinds of mitral regurgitation. Primary, which usually have a clinical picture of heart failure with preserved ejection fraction, and we are interested for our purpose for interventional transcatheter treatment with myxomatous and fibroelastic. Usually the mitral valve is diseased and the ventricle is hypertrophied but is well functioning. And the fibroelastic and myxomatous are differentiating between, because usually fibroelastic is more for old patient and the myxomatosis is present in a younger patient. When mitral regurgitation appears in patient, the prognosis, the survival is reduced. And this paper, Dr. Serrano showed how using this quantitative measurement, the ERO, if all the patients who had a ERO more than 40 square millimeter had a very bad prognosis when compared to those with 20 or less than 20. Secondary mitral regurgitation is a huge category of patient where the mitral valve is normal, is well functioning, but we have disease of the ventricle. So we have valvular dysfunctions and secondary to left ventricular remodeling. We have geometrical and functional changes, and also we have papillary muscle displacement. This is a specimen in which we can appreciate the difference with the primary mitral regurgitation. Left ventricle is enlarged, the walls are thin, but mitral valve is normal. These are the mechanisms. Briefly, in left ventricular dilatation, we have displacement of papillary muscle, so we have a reduction of the coaptation of the valve, and we have enlargement of the annulus. When mitral regurgitation occurs in those patients, the natural history is worsened, so we have really bad prognosis, as showed by these two papers. For ischemic, we have a slightly different mechanism. We have a tetering of the papillary muscle, so we have reduction of coaptation. Also here, when we have an ERO more than 20 square millimeter, we have very bad prognosis. And if we compare with the primary mitral regurgitation, we can understand how secondary mitral regurgitation has worse prognosis in general. And this is because we have also left ventricular dysfunction and other comorbidities. Surgery has very good result in primary mitral regurgitation. In secondary mitral regurgitation, the mortality is a bit higher because of older patient and comorbidities. In patients with advanced heart failure, surgery has been used, but without very good result when compared to the other mitral regurgitation. So why saying that? This is because now we are having a lot of device, and we are having some different indication for this device, and then we will talk to you later on. The imaging is very important. It's crucial. It's crucial not for diagnosis, but it's crucial for planning the procedure, for understanding if the patient is suitable for the intervention technique, and also for monitoring the procedure during the intervention. This transcatheter echo is the first line. Everybody knows we have a lot of parameters for understanding the severity of mitral regurgitation, and here the echocardiographer now have a lot of information. They can really say to us if the mitral regurgitation is severe, and helping us in the indication. Transthoracic esophageal echo is important, not only for diagnosis, but also for understanding the mechanism, the etiology of the mitral valve, so we can understand if the patient is suitable for transcatheter intervention, repair, or replacement. 3D echo is a very nice imaging technique, and is very useful always for better understanding of the mitral valve anatomy, because it gave us a 3D reconstruction of the valve, and we can observe in all the view from atrial or ventricular view. CT scan is becoming also a very important tool, especially for patients who are candidates for transcatheter valve repair, because we can understand the geometry, we can have some measurement, and also we can plan the procedure in advance, especially for those procedures which needs transeptal access. Mitral regurgitation is undertreated, and this is a multi-sided paper published in 2007 from a Euro Heart Survey, where was showed how 49% of patients with mitral regurgitation indication to surgery were not treated. We have a lot of device. The only device which survived is the mitral clip. The mitral clip is reproducing the edge-to-edge Alfieri stitch technique. So we created double orifice, and in this way is reducing the mitral regurgitation. Double orifice mitral valve is a model which already exists because it is a very rare congenital heart disease. And usually these patients came to our attention not for the mitral anomaly, but for associated defect like atrial septal defect or ventricular septal defect. The mitral clip system, everybody knows, is now used everywhere, is a very good penetration, even if in Europe the indication are a little bit different from US. In US, the main indication are primary regurgitation. In Europe, we treat both degenerative but also secondary, but the 70% of patients treated in Europe have functional mitral regurgitation. This is because these patients have a higher risk profile, have comorbidities, low ejection fraction. I don't explain you the device because everybody knows, I think, but this is the clip which grasps the two leaflets in the regurgitation place. This is the quick description of the procedure. We create a double orifice mitral valve, and the 3D echo is very useful, especially in navigation of the clip in the left atrium. This experience with mitral was very important for me because in these years I really understand a lot about mitral valve and transcatheter intervention. So this is the first patient I performed in 7 October 2008. Was a patient who had already a core valve in the aortic position, but he had this mitral regurgitation we solved with a mitral clip. We learned how to orientate, how to understand the echocardiographic image. Beginning, we had these kind of maps. It was given by the company because we have to understand the anterior posterior orientation, lateral septal orientation, and we started to use these three standard projections, which are now routine: the three-chamber, the intercommissural view, and the short axis. We learned how to perform targeted transeptal puncture. And echo was very important because we can see perfectly where we are placing the needle, and also because floor was not useful. Because here, if you notice, this orientation, this needle, is really not usual for safe transeptal puncture. But for mitral clip, it's very important, and we can do it because we see where we are puncturing. We learn how to puncture in posterior superior part because the mitral valve is posterior, and to puncture at a certain level from height from the mitral valve. We learn how to manage very difficult septum, especially patients who sometimes have a CRT or has already other operation. We have a very thickened septum, so we developed some technique for overcoming this issue. 3D echo was very important, and with this transcatheter mitral valve intervention was developed, and we really appreciate very soon the utility in navigation of the mitral clip, so we can understand where we are, if we are perpendicular and if we are central. Personally, I prefer to use only the X-plane procedure because with the X-plane we really shorten the procedure because we have in contemporary two orthogonal view. We learned how to interact with echocardiographer. When the 3D echo came, my echocardiographer was hypnotized from these wonderful images. But finally, he understood how to follow the procedure, and so also came out of the echo, the figure of echocardiographer who is specialized in intervention. The CT scan was very important. This is a patient treated in 2011, I think 2010. He had a pulmonary, he had a left pneumonectomy. So I performed CT scan for planning the procedure, for planning the transeptal, because all the heart was displaced in the left part of the chest. And so in this case, I planned to place the wire in the left ventricle for inserting the delivery catheter. And also the transesophageal imaging were different. So we obtained a three-chamber view at 90 degrees rather than 140, and interchromacy views at 25 rather than 60 or 70. This patient, this is the only patient I refused because of this carcinoma and the mediastinum. The patient could not be treated for really bad quality imaging with transesophageal echo. But very important also, I understand and I appreciate the fact that the interlateral communication after procedure could be a problem. And the first 30 patients, sometimes I had some patients with right failure after the mitral clip, even if the mitral clip was working very well, and the interlateral communication was more. But then I understood that this small shunt, which usually is not more than 1.4, can really have a bad hemodynamic impact in patients with pulmonary hypertension, with right ventricular dysfunction, and with low left ventricular ejection fraction. So I started to close this communication, not in all, but only around 10% of patients when the hole is larger than 10 millimeter. And when we have a bidirectional shunt after the procedure. This concept is not, I didn't discover nothing, because this concept of the impact of antiseptal effect, also small septal defect in patients with low left ventricular ejection fraction, was described by Professor Rudolph in his historical book about congenital heart disease of the heart. And also I learned how to start with the first patient without intubation. All the patients were intubated because of transesophageal echo, but this patient was absolute contraindication to anesthesiology, and then we managed to perform without intubation. Now, actually, my routine practice, I perform 90% of patients only in conscious sedation. And also we understand how to manage double valve. I published this paper in 2011 with the first two patients. And it was really a big challenge because we had a mitral regurgitation for rupture of chordae tendineae and severe aortic stenosis. Then we should understand, we were trying to understand if it was better to perform a mitral repair or aortic stenosis repair before. And I discussed with the surgeon. They told me that it's better to do performance aortic stenosis, and I did, and it was very successful because I did TAVI first, and then after 1 month, mitral. This because if we treat mitral regurgitation first and we leave the aortic stenosis, we can have an abrupt increase of the afterload. So the patient can suffer with this abrupt, so the left ventricle cannot manage this acute afterload. Now the clip is becoming a reality, and now there are auto trials going on here in the US. There is the QAP trial, it's a very important trial. In Europe, we had the reshape, which was the twin, but was interrupted because we are treating this patient with functional mitral regurgitation. It was very difficult to enroll the patient and to randomize it. We have other option, the annuloplasty. Direct annuloplasty, indirect annuloplasty. This device, which has been acquired by Edwards recently, is the Cardioband. It's very interesting because it's simulating annuloplasty, surgical annuloplasty. It's transeptal procedure. It's very elegant, a little bit long because you have to screw this sock in all the annulus. But the main problem is the imaging, and so also patient selection is very, very strict. The results are good in 85% of patients. This is one patient. The indirect annuloplasty is another procedure which is less effective than the direct annuloplasty. This carillon is placed in the coronary sinus. The results are also good, but not as good as the direct one. Now, let's speak about transcatheter mitral replacement. It's the new frontier, and it's a new challenge. And with this technique, we want to eliminate mitral regurgitation, preserve leaflets and subvalvular apparatus, minimize LVOT obstruction and paravalvular leak. But also we need a safe procedure and efficacy procedure, and also the procedure must be reproducible. So we need to have an easy procedure that everybody can perform. The problem is that we know that the mitral valve has not real annulus when compared to the aortic valve. There is interdependence with the left ventricle, and there are relationship with very important other structures. The mitral valve is large, so we need large prosthesis, and these need a big delivery catheter diameter. So only for percutaneous approach is the problem, because the navigation with the cardiac chamber is difficult because the curve between right atrium, left atrium, and left ventricle is very, very steep. The access now used in all the devices which are under investigation is transapical, because it's more direct, is easier. Transeptal is very complex, but there are a few valves with transeptal access. And now, for sure, the experience that we had with valve-in-valve in mitral biological prosthetic valve or valve-in-ring helped us also to perform a better procedure. This was described first by Webb, and mostly is used Sapien XT. I think also here you use a lot of this valve in this procedure. You can use it in transapical and transeptal. In Europe, the transapical has CE mark for valve-in-valve treatment. The other fruit is mitral annular carcinosis. Even if the selected patient, you can place the Edwards valve. The problem is that we are using a valve ideated for aortic valve, but in mitral position. So the results are not great, but are satisfactory. Here we have the scenario of mitral valve prosthesis. These are the only under investigation use. Tendyne is maybe the valve most used, and there is only transapical access. It consists in placing and opening this valve in the left atrium and then fixed to the apex with a paddle. And these are the results are very good. This is the echo imaging. So, but this is only with transapical access. 12 Intrepid, I know that you have a good experience, is a transapical valve. There is independence between the valve and the part which fixates to the annulus. And also here the results are very promising. I will speak a little bit more deeply about cardiac Q, because it is the only valve which was created for transeptal access, and we have done few patients with transeptal access with very good result. This is the second generation actually, and so we have these anchors, which are the main mechanism of anchoring in the left leaflets, and the valve is not stenting the annulus. Is very important. The skirt is open, is sealing the annulus during systole, and the cells in the left atrium are open, so we can have guarantee a good blood flow and reduce in this way the formation of clot in the left atrium. This design, tapered part, is also helping to avoid LVOT obstruction. The first valve was implanted the transeptal in 2012 with the first generation, but then they stopped the problem, they renewed the design, and they started with transapical. These are the two axes, so we have transapical version. The valve is always the same, it changed only the delivery system. This is my experience in 2015, 4 patients treated consecutively. The first 2 were transapical, the second 2 were transeptal, and with 100% of procedural success. Now this patient, the patient number 1 and 3 are having a 24 months of follow-up, so are surviving. The second patient died 5 weeks after. Was the 6th patient with very low ejection fraction, pulmonary hypertension. And so here in this patient, we learned how it is difficult to manage a patient after transapical access, especially when they have a very diseased left ventricle. These are some data about the procedure, just for noticing that the first transeptal was 120 minutes, and the second one was shorter. and also the intubation time was much, much shorter. So we expected the last patient in the cath lab. This is the first patient, was transapical access. Now was mitral regurgitation, secondary mitral regurgitation, head cabbage, left main PCI, and GI bleeding. All procedures were performed under compassionate use. Now, it was very important to plan this procedure, and after a long discussion with the cardiac surgeon, the perfusionist, and the anesthesiologist, I decided don't use the extracorporeal circulation as support, because the company was suggesting us to use extracorporeal circulation for supporting the ventricle during all the maneuver. But I discovered that maybe this could be not useful, but maybe can worsen the ventricular performance. So the patient was prepared with cannula in the femoral artery and femoral vein, but we never use extracorporeal circulation. This is a setting, is a very big delivery cutter. We use the pneumatic arm for having a good position, so for avoiding abrupt moment. The valve is inserted in the, once the wire is in left atrium, the valve is inserted, then we open first the left ventricular anchors, which flips, and it was another very important point. I was surprised that we have very good imaging of the flips and the relationship between the anchors and the leaflets, because we have to count every single anchor that were grabbing correctly the leaflets. There are 12. The patient was very stable during all the procedure. Despite having this big device inside the mitral valve for almost 2 hours, the patient had really, really stable hemodynamic. These are all the steps. So first we deliver the anchor in the left ventricle, then we open the central part, and then we deliver the valve in the left atrium. This is a left lateral view of the valve, so you can really appreciate the valve and the relationship with the left atrium. But also here in the ventricle, you can see very well all the anchors. So we really were analyzing millimeter by millimeter all the relationship between the valve and the left ventricle. This is the 3 months follow-up. You can see that the left ventricular ejection fraction improved. Was really, we didn't expect it. This is the last follow-up at 24 months, 26 months for follow-up. I saw the patient just before coming here. Now, and also here is very important, the most critical point, the LVOT gradient. We didn't have any LVOT gradient, even if the valve was a little bit lower than the side. And the patient in functional class 1. Now, then we performed the second patient, but we had a little bit experience with the transapical access, because the patient, the valve was perfectly placed, it was functioning, but the ventricle was not recovering very well after the transapical suture. So for this reason, we were really committed to perform a transeptal procedure. It was the first time with this kind of valve, so we have to plan the transeptal puncture. And we have 2 critical points. The first point was the navigation of the valve, or the capsule, which is long, 7 centimeters long, and is very rigid, 30 French, from the right atrium to the left atrium to the left ventricle, and also to the orientation, the alignment. So the transeptal puncture was planned to perform 2 transeptal puncture. So the first one was posterior superior for the delivery system crossing the septum, and then the second one was lower, posterior inferior, about 10 millimeter more or less. I tried to calculate the puncture using the CT scan. And this because we need to have a different alignment of the wire, of the snare for pulling the device during the navigation in the left atrium. So this is the first puncture, this is the second puncture. We can see very well in 3D echo. And here is the snare system inside the steerable cutter, so we can move the snare very easily, and so we can control where the snare is going, because otherwise the snare goes everywhere. And the wire for the delivery catheter is inside the snare, it's crossing the snare. Once perform these two transcatheter puncture and place the wire in the snare, we had to do the loop. Now, creating the arteriovenous loop is very important because we need a 5 meter, to place a 5 meter wire which enters from the right femoral vein, goes inferior vena cava, cross right atrium, left ventricle, aorta, and they come out from the femoral artery. And the problem is that we have to avoid the mitral chorda. So they suggesting us to use Judkins right or pigtail, but we were going always through the chorda. So we used this Swan-Ganz cutter, which very easily actually cross all the loop and without entangling any chorda. So this is a maneuver. Actually, we lose at least 30 minutes for having a good crossing with the other catheters, but with this in 2 minutes we had a really good placement. Then was the critical point was to navigate to place the valve. So you see how it's long, 7 centimeters, is very rigid. By pulling the catheter and pushing the catheter and pulling the snare, we're able to orientate, even if it's a bit traumatic here, to orientate the valve inside the mitral valve. And then we were able to implant, try to align the valve using this loop and several maneuvers. But you can see how is very well, we can see very well the relationship between the anchors and the leaflets. This is the final result. This is not, and this is the triaco. Here we have to close the internal communication because it was tearing, and we use a PFO 35 millimeter device. The patient was charged for 4 days. And this is the follow-up at 12 months. Also here we have improvement of the left ventricle, but after 6 months, the patient had some dyspnea because he was developing some aortic stenosis, not a big gradient, 30 millimeter mercury gradient. But what was happening was that there was a residual shunt from the intermittent septum. So by only closing this shunt, we really had a very good improvement of the symptoms. And again, this underline how it's important to assess the residual shunt even if it seems to be small. This is the last echo. He's developing some aortic stenosis, aortic vegetation. Maybe we will implant the future aortic valve. The central transcatheter patient was much better because we already know what to do, and we better know, and the double transcatheter. But most important, we were able to orientate much smooth way, very less traumatic way, the catheter inside the mitral valve. The valve was implanted in very few times, in 90 minutes. The patient was extubated in 20 minutes after the procedure and in the cath lab. This is the left ventriculography after, so we can see how we have very good results. And I want to notice that because we were less traumatic, we have really 2 really small holes. So in this case, we really improved the procedure with the second patient. Now there is the company is developing this steerable catheter, which is under trial here in the US, not in Europe yet. Then we had this double transcatheter technique. Everybody says that maybe it was too difficult or not reproducible, but I think that is very easy and reproducible. And then also I used this with another mitral valve intervention. There was a patient with degenerative mitral valve prosthesis, very stenotic, and there was a perimount adult. So I want to use a melody valve. The valve is used for transcatheter pulmonary valve intervention. And I thought could be very easy because it's only 22 French, is softer, but we were not able to cross without help of the snare. So again here, with double transeptal technique with the snare, we were able to cross again the valve. And done this in 2 patients. So seems to be difficult, but it's not difficult. I think that is very useful. So all the concerns that we had before we performed this transcatheter mitral valve, avidity of obstruction, conduction system compression, circumflex artery compression, impact on left ventricular physiology, and procedural events didn't happen with our 2 patients. And also I can tell you that these 2 patients are only on aspirin, are not receiving any anticoagulation drugs because they have both a contraindication to anticoagulation. And they are doing very well without any thrombosis of the mitral valve. So we had a very good experience. Now for pursuing the transeptal, then the transapical is that because we have our personal experience, but also is well known that transapical, this is the paper about the valve in valve registry for mitral valve, and they showed how the transapical group had a lower ejection fraction respect to the transeptal in the long term. So future perspectives, we are still in very early era of this procedure, but we need to improve this transcatheter mitral valve replacement technique. The devices are still very big, and we should pursue also the transeptal access. When we will have also transeptal access, we have to understand if transeptal is better than transapical or not. And when we decide this, we have to understand if transcatheter mitral valve replacement will be better or not with respect to the valve repair. Thank you for your attention.
So, Gian Paolo, that was great. So many, many thanks for this talk. Now, by tradition, no one ever finishes grand rounds on time. So we're going to have to ask security to step in and to bring the SWAT team to help us control the situation. But, so your talk obviously is a glimpse into the future and raises lots of questions for us. So first, as we have debated for a long time in surgery, mitral valve replacement gets better. Now, replace or repair? That's number one. And then the tougher question is next. So replace or repair percutaneously?
No, it's very difficult to answer now at this point. Now, what we noticed after the transcatheter mitral valve replacement is that all the patients, and I showed you only patient because who survived, and with a longer follow-up, they improved the left ventricular ejection fraction rather than reduced. The second one was very sick. He didn't improve a lot because he had transapical, and so was. But the other 3 patients were all secondary to ischemic cardiomyopathy because they had bypass and the coronary CAD, coronary artery disease. We have a slight improvement of the left ventricular ejection fraction. So this really surprised us. And we would like to understand better because we need more patients. It's very, very small and serious. But maybe I think that maybe with transcatheter technique, replacement will be better than repair with transcatheter technique. It's not the same with surgery where repair is better than replacement.
Okay, so the second question is the ReShape and COAPT trials are going on now, which are the first randomizations for functional mitral regurgitation between an intervention and aggressive medical therapy. If those trials turn out to be negative, so if there's no benefit for the clip versus medical therapy, What does that do to the future of transcatheter mitral replacement? And then an even tougher question is next.
Now, this is a very good question. Now, what we noticed since the beginning was that patients with functional mitral regurgitation, very low ejection fraction, were having very good behavior during the procedure, were very stable. Even patients with very low ejection fraction. Because in the beginning, we were treating also patients with 20% of ejection fraction, where patients who didn't have any other option. And in this patient, we noticed at least a very good improvement of the quality of life. So what happened? It happened that medical was created for degenerative, but in Europe, after the first year, the 70% of procedures were performed in functional with low ejection fraction. And we had this experience of improving of the quality of life. Then we learned that patient with very sick patients, so with low ejection fraction below 20%, with pulmonary hypertension, right ventricular dysfunction, where the patient we cannot treat because even if we had a perfect result, the patient was not having any kind of benefits. So we are quite confident in Europe that the MitraClip example is very useful for reducing, not maybe for have better survival, but for reducing the admission and the heart failure episodes and for improve the quality of life. Also because the results are much better with functional respect to the degenerative. This is because the mitral valve is normal. So placing a clip in this patient is very quick, very fast, very effective, and very often we need only one clip rather than two. With degenerative, sometimes we need to put 3 clips because now the degenerative valve, especially when there is myxomatosis, are very difficult to treat correctly.
Oh, congratulations. I enjoyed your talk greatly. I think this is a very fertile field, especially in the high-risk people. Well, just from a technical point of view, I think for people getting into this, they need to remember that the aortic mitral angle is significantly altered when a prosthesis is present. So for the valve in valves, it's not unusual to encounter a prosthesis that's facing the septum rather than facing the apex. And that was probably, you overcame it very elegantly there, but that's something people need to not be surprised by when they encounter that situation. Yeah. We do have data from the ACORN trial, which you may recall was using the sock, restraining sock on the outside for people with cardiomyopathy. And there was a subgroup in that of mitral valve repairs in people with low ejection fractions. And in that study, even in people with ejection fractions in the high 20s, the perioperative mortality was in the range of 1%, and the regression and improvement of left ventricular ejection fraction over the next 3 to 6 months was quite striking. So we do have a model to show that if you relieve MR in people with low ejection fractions, many of them, even with functional MR, will improve. Just like we've had in TAVI, the older populations clearly are ideal. These high risk, very sick, redo, bad pulmonary hypertension, all these risk factors type of people will clearly benefit from these therapies. The issue, as we're confronting in TAVI, is how low to go in terms of age and what the durability is going to be. I just reoperated on a patient the day before yesterday. We'd done a mitral valve repair on 21 years ago, and the repair was still intact with no MR, but she developed mitral stenosis from mitral annular calcification. So we do have a lot of data showing 15 to 20-year durability with successfully repaired mitral valves. The repair rate we've achieved now here in degenerative disease is 100%, and perioperative mortality is 0.5%. So surgery, I think, is still competitive, especially in the lower age groups where durability is going to be a very important issue. The mitral valve, of course, has nearly double the strain on it during systole that the aortic valve does. The aortic valve is subjected to 70 millimeters peak pressure, and the mitral valve is subjected to 120. So I think we may have to pay even more attention to durability. These are engineering issues, which I'm sure eventually will be overcome, but I think what's not been fully recognized in the TAVR sphere is that the TAVI prostheses are really lightweight versions of the bioprosthetic valves, which have pericardium twice as thick and very nicely engineered, stable engineering configuration in terms of stress dissipation on the leaflets. And that as we come into the younger age groups, there may need to be some further attention paid to the engineering of valves designed to go the distance in the younger people.
Well, we're clearly not putting them in 6-year-olds.
Well, you would if you could.
Yes, yeah, correct. Thank you
And
for-
remember, my grandchildren are a lot bigger at 6 than we were.
Yeah. Thank you for the comment. Yes, but for TAVI, I am very optimistic because we have for now a lot of patients after TAVI, and at 7-8 years after implantation, because we started in 2007, we are having very good results. Very low for some reason, very low. At least I'm speaking about core valve, the Medtronic valve, and the Edwards, because they are the first implanted with very low rate of structural deterioration. And also, for some reason, we have very low incidence of endocarditis. I don't know why. Even if we are not, we don't respect as in surgical room, because we are not as perfect as surgeon, but we have very low endocarditis. For mitral valve, the big challenge is this, because we have large valve, large leaflet, the pressure is different, the gradient is much more, so every leaflet has much higher hydrostatic load per square millimeter. So this is engineering challenging. They are trying to fix it.
Enjoyed very much your presentation. An evolving field, challenging, but certainly quite impactful ultimately. 2 questions for you. One, how do you address the potential complication, or at least maybe different planning or selection of patients for left ventricular outflow tract obstruction and interference of the mitral valve? So that's one. And 2, as we struggle to write the guidelines on how do you evaluate residual mitral regurgitation with the mitral clip, what's the Italian experience of how do you use? Do you use hemodynamics? Do you use TEE? Do you use a combination of all the above to assess residual mitral regurg, which is really a difficult issue?
So for addressing the complication, we try to avoid LVT obstruction. Now, the first transapical patient, the valve was implanted a little bit lower, and we have some gradient after procedure, 25 millimeter mercury. But after 3 months, this gradient was relieved for some reason. And I had also another experience about valve in valve, where there was a very small ventricle, very small lady. The mitral prosthesis biological was just inside the LVOT. When I put the valve, I had some obstruction. And also in this case, after 2 weeks, the obstruction was relieved. We have to avoid this, obviously, because it's a very important issue. And I think it will be a matter of engineering design of the valve for avoiding this problem. About mitral regurgitation after intervention is a very good point. See, we don't have the correct answer. Personally, I think that the best way will be maybe or nuclear scintigraphy. It's a very old system, but maybe we can really better understand the mitral regurgitation volume. But we are using echo. We are using echo and 3D echo for understanding. And also we are using the relationship between the timing of the regurgitation. Because after mitral clip, we can have some moderate regurgitation, but maybe it's all end systolic, is just at the end. And so the amount of blood which is coming back is lower.
So, Gianpaolo, Alfieri took the position that he would no longer do edge-to-edge repairs without putting a ring in also. So can you comment on combining some of the mitral repair techniques, one of the plication technique plus a clip?
Yes, I think could be really a real scenario. The problem is only economic, because if we do this kind of procedure, it will be very, very costly, very expensive. But performing first the direct annuloplasty and then the second time same session or maybe after a clip, I think could be really, we can have really good results theoretically. Now we have to see.
And we have talked about it, personally, but this is the forum. Dr. Kleiman just pointed out about, possibly combining cardioband with MitraClip and compare possibly with replacement. But you mentioned an economic cost to it. Also, the preservation of surgical option or a valve in ring option would possibly lead us more towards doing an annuloplasty first approach. How do you think these evolving percutaneous repair techniques, they will be one winner and probably cannibalize the other repair techniques?
I think it will happen like in TAVR scenario. Now we have a lot of TAVR prosthesis, so we are able to choose the right TAVR for the patient. So we can we can select the device for the patient. So I think also in mitral valve scenario we have this option. When we have more knowledge, we can choose the better treatment for that patient, basic on anatomical and functional.
So the only problem with that is because MitraClip emerges from an imperfect technique. TAVR is a cure. MitraClip is what we have. So we could imagine a scenario where we did a cardioband and then there was recurrence. You could put a valve, some kind, in that valve. But if you put a MitraClip first, then you possibly rule out a facile surgical option, a facile transcatheter option. You only are left with an annuloplasty option. And that too is, yeah. So, a very interesting scenario which could lead forward. And MitraClip could disappear.
Oh, thanks. So you alluded to, thank you again for that great overview. So you alluded to a case with combined aortic stenosis and MR and the decision-making around TAVR or MitraClip and which one first. So I'm interested in sort of how you work through that, because we've had similar experiences here and we've tried it both ways, and I think we're still trying to figure out exactly. And I think our sense is if it's functional MR, it makes sense to go for the TAVR first and relieve the pressure and see what happens. If it's primary or degenerative MR, sometimes the AS quantitation is difficult because you've got the lost flow of the MR and you're really wondering how severe is the AS, and maybe once you clip the mitral valve, the AS will look worse. So how have you approached that problem?
Now I've done not much too many, but maybe 10 or 12 this kind of patient. See, now I prefer always to treat if the patient has aortic stenosis. First, treat aortic stenosis and with TAVR, and then wait a few weeks for two reasons. First, because when we put TAVI, we can have some left ventricular remodeling, change of the relationship between the left the anterior and the posterior leaflet. And so sometimes we can have a reduction of the mitral regurgitation. If it's not, we can have maybe a better results putting the clip maybe in the correct way. The second point is because when treating first mitral regurgitation with aortic stenosis, even moderate, really we can have some left ventricular overload. I've seen this case. Was not my personal experience, but treating first the mitral valve, leaving also moderate aortic stenosis, we could have some hemodynamic impairment. And it's not infrequent that our colleagues are sending us patients for mitral regurgitation, and they come out, they have aortic stenosis. For me, when I have this kind of patient, I really carefully rule out if there is aortic stenosis. And if it's mild, I just keep in mind, so maybe we are ready to do something if we have some problem after mitral implantation. If it's moderate or more than moderate, I think to treat first the aortic valvulopathy.
Thank you.
Thank you very much.
Thank you.